Anyone who works in primary or acute care knows exactly what they're in for every year when influenza season starts. You will see a lot of patients with fever, most of whom will have influenza. Our top priorities are to identify patients with influenza who are at high risk of influenza-related complications so that we can start antiviral treatment in time, and to identify those who already have a complication or another bacterial infection that will require antibiotic treatment or hospitalization. In a sea of febrile patients who all present in a similar way, it's easy to miss the ones with unexpectedly severe conditions, especially if you work in a remote area with limited diagnostic capabilities. So, I'm going to share some crucial tips for surviving flu season that are easy to miss in literature and guidelines, but they will help you a lot in dealing with the most common dilemmas in practice. This video is intended primarily for primary care and emergency physicians, but I believe every medical worker will pick up something useful, so let's begin. What can you expect from antivirals and who should get them and why? Every year I remind my colleagues that influenza has been a treatable illness for quite a while now, and that we can and we should treat influenza in people who are at risk of influenza-related complications. This includes young children, people over 65, and people with chronic conditions. What chronic conditions, you might ask? Basically all of them. You cannot miss here. Naturally, neurologic, heart and lung disease are the most important, but all kinds of kidney, liver, and endocrine diseases are also reason enough to start antivirals. How soon? As soon as possible after symptoms start, preferably within 48 hours, because the earlier you start, the more dramatic the effect will be. If treatment is started on day 1, it's quite likely that the patient will feel completely fine and symptom-free already after a day or two, speaking from experience. On the other hand, if the virus is allowed to multiply and spread throughout the system for 48 hours or more, the effect of antivirals will be far less noticeable and far less impressive. But at least treatment will still offer some protection against the most severe complications. So, in people who are at risk, start treatment and do it as early as possible. Be sure to prescribe antivirals even if the patient was immunized. Immunization does significantly decrease the probability of severe complications, but high-risk patients need all the help they can get, especially if they are immunocompromised and cannot mount an effective immune response to infection or vaccination. Oseltamivir is the most commonly used antiviral drug for influenza. It's safe, widely available, well-tolerated, and quite effective if started early. But if that's the case, why not just treat everyone, even people who are not at risk, like young and healthy athletes? Well, with young and healthy people who come down with influenza, if treatment is started more than 48 hours after the onset of symptoms, it will probably make no noticeable difference. Their probability of complications is extremely low to begin with, and starting treatment that late will not shorten the duration of symptoms or provide additional comfort. That is why most experts recommend that in healthy people with no risk factors, you only start antivirals if they present within the first 48 hours. After that, it's of little use. Speaking of risk factors, heart disease, lung disease, all of this is pretty obvious, right? But there are two incredibly important risk factors for severe influenza-related complications that often get missed. The first one is obesity. We talk all the time about age and chronic diseases, but obesity somehow slips under the radar, and it shouldn't. I see the same thing every year, every single time, and I can attest from my own experience that obese patients are much more likely to end up in the ICU, on mechanical ventilation, and suffer the most severe complications of influenza, including respiratory failure, fatal arrhythmias, and even death. And this holds true even if they are still young and with no known chronic conditions. Obesity in itself mutes the immune response to viruses, especially in the lungs. It increases the physiological load on the heart and the lungs, and even it mechanically impedes ventilation. So remember, yes, your patient might be otherwise healthy, but if they are obese and they have the flu, I would certainly recommend antivirals and a follow-up. Doctors should know this, but also patients, so they seek medical attention early and get potentially life-saving treatment in time. The other risk factor that often gets missed is advanced pregnancy. And if you think about it for a second, it makes sense, doesn't it? Pregnancy in itself is characterized by relative immunosuppression. Also, there is an increased physiological burden on the heart and the lungs to supply the placenta. And finally, the mechanical effects of advanced pregnancy with the large uterus pressing against the diaphragm impede normal ventilation. And this is why so many expert societies recommend routine vaccination of pregnant women, especially if their term overlaps with influenza season. Naturally, this should not be a live vaccine, but the more common inactivated or recombinant vaccine. Not only does this provide protection for the mother, but it also confers partial protection to the infant. Naturally, the fact that pregnancy is a risk factor for severe influenza also means that pregnant women who already have influenza should receive treatment with antivirals as soon as possible in order to prevent complications, of course. The next problem so many clinicians face in influenza season is distinguishing influenza from more severe bacterial infections. So in flu season, when you see hundreds of patients with fever and respiratory symptoms, it can be very difficult to tell the difference between uncomplicated influenza and pneumonia, the most common complication of influenza, or other severe bacterial infection like sepsis of any source. We've all experienced how brutal the onset of influenza can be. It's not called influenza for nothing, right? It deeply influences you. Rigors, chills, high fever, muscle pain, extreme malaise. In many ways, influenza can mimic the onset of a severe bacterial infection like sepsis or pyelonephritis or pneumonia, especially since respiratory symptoms can often be absent early on. So, how can you tell the difference? Patients with uncomplicated influenza might look very sick, but they should not show signs of organ dysfunction. This is paramount. There should be no dyspnea, no hypoxia, no hypotension, no signs of kidney failure, and no altered mental status. None of that. If any of these signs are present, either this is not influenza or it's not just influenza anymore. In other words, you should look for severe complications that have already developed, primarily pneumonia. Again, it's especially difficult when there are no respiratory symptoms at all and you just have a patient with rigors, chills, and high fever. This might still be influenza, of course, and many times it will be, but you should take your time and at least consider the possibility of a severe bacterial infection, like again, bacterial pneumonia, acute pyelonephritis, sepsis of any origin, etc. So examine your patient thoroughly, pay attention to vital signs, and if you can, do some tests, which we will talk about next. Let's start with rapid tests. A quick and simple test that can help you is a rapid antigen test for influenza. Sometimes you get a combo test for COVID and influenza. These tests are cheap, simple, fast, they can be done anywhere, they are widely available, what's not to like? But if you've seen my videos on respiratory infections, you know that the sensitivity is far from perfect. It's only about 50 to 60% for influenza, so this is a major drawback. In other words, if symptoms fit and the test is positive, this is likely influenza. But a negative test does not exclude influenza in any way. So, if your patient is at risk of complications, start treatment with antivirals right away, even if the test is negative. If the symptoms fit and it's influenza season, start treatment for influenza. Naturally, you will be careful, you will go through your differential, but don't rely on rapid antigen tests to rule out influenza. The sensitivity is just too poor. What about other tests? Well, if you can get a CBC with differential in influenza, you will usually see a normal leukocyte count with relative lymphopenia and mild thrombocytopenia. This is typical. So normal neutrophils, low lymphocytes, and platelets around 100 to 150. This is typical. What is not typical, however, for uncomplicated influenza is leukocytosis with neutrophilia. If you see that, suspect bacterial infection, especially, of course, bacterial pneumonia. If you happen to have a point-of-care CRP analyzer, you will see that in uncomplicated influenza, CRP is almost never higher than 40 and procalcitonin doesn't go above 0.25. The next crucial question is, when should you order a chest X-ray? Because, of course, again, pneumonia is the most common and the most significant complication of influenza. So, when will you order an X-ray? Again, vital signs come first. low O2 saturation, and increased respiratory rate are red flags. Also, although fever in influenza can last for almost a week, even in uncomplicated influenza, I still like to see signs of improvement by day 4 and definitely by day 5. If there is no improvement, I will suspect a complication, usually pneumonia, and I will order the X-ray. If you've seen my lectures on influenza-related pneumonia, you know that there are two overlapping types. Secondary bacterial pneumonia, this is the classic one, so influenza opens the door for bacteria and pneumonia occurs later in illness, sometimes even after a brief improvement. This is the most common scenario. But there is also primary viral influenza pneumonia. Since this is caused by the virus itself, it occurs earlier in the course of illness, around day 3 to day 4, and it can affect unusually young patients and patients with no significant chronic conditions. This is typical, and you will usually see when H1N1 strain is the dominant strain in circulation. And the important thing about this primary viral pneumonia is that once dyspnea appears, it can progress very rapidly to respiratory failure. So, be very careful. Even if your patient is young and seemingly otherwise healthy, if they develop influenza-related pneumonia and dyspnea, this is a very serious finding, and know that this could rapidly progress to respiratory failure. Regarding treatment, the point is, if your patient with influenza has signs of pneumonia, especially early, don't forget antivirals. Yes, you will start antibiotics, of course, because even in primary influenza pneumonia, bacterial co-infections are very common. Just don't forget that, in addition to antibiotics, antivirals are essential in primary influenza pneumonia, and they often get overlooked. That is why I emphasize this. Share this message with your colleagues, students, anyone working in primary care and acute medicine. I'm confident you will help many patients that way. Best of luck. Take care.